This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on lateral lumbar interbody fusion. So lateral means going from the side, which sounds kind of crazy. We're trying to get to the lumbar spine, your lower back, and we want to fuse one of the segments. And we can either go from the front, the side, or the back to do that. And sometimes we do a combination of a couple of them. Sometimes we do all three in a certain person. But the lateral means from the side. There's other terms for it called an XLIF, which means extreme lateral, or a DLIF, which means direct lateral. But regardless, the L at the beginning means lateral. The second L means lumbar, and then the IF at the end means interbody fusion. So lateral or XLIF or DLIF or LLIF all means lateral interbody fusion. Interbody fusion means we're going to take the disc out and fuse the vertebral bodies. So the vertebral bodies are what's numbered, L1, L2, L3, L4, L5, and then S1. The discs are in the middle, so the discs have two numbers. So the discs are L2, L3, for instance. If they're in between the L2 and the L3 vertebra, the numbering gets confusing. You have to do this for like 10 years before you really get it, and patients never really get the numbering right. But that's basically the gist of it. The vertebral bodies, the bones, are numbered. The discs are in the middle, so they have two numbers. So if a disc is painful because it's so degenerated that it's collapsed down and there's a slippage there or scoliosis or it's herniated several times, if the disc is incompetent and it's causing a lot of pain and problems, we fuse it. We basically just get rid of it, which means we take out the disc, put in some bone, which may be in a metal or a plastic cage, a spacer, and then put some screws and rods in to stop the motion. So you stop the motion, and that allows bone to grow across the disc space. So one vertebral body fuses to the other vertebral body. The two bones literally fuse together. They grow together. That's why it's called a fusion. They never move again. They never hurt again. And the pathology gets treated. So the interbody fusion of the IF, the XLIF, the DLIF, the IF, the ending part is interbody fusion. It means take the disc out and fuse the vertebral bodies. And that's the most effective way to get a fusion because that's where all the biomechanical activity is happening through the disc space. The disc holds 80% of the weight. For every disc in the front, you have two facet joints in the back. The facet joints are not that big. They hold about 10% each, 20%. But the disc is 80% of all the biomechanical activity and motion and stress, and that's where usually all the pain comes from. So if you're going to fuse a motion segment, fusions that were done 20, 30 years ago were all done from the back. Well, the problem is around 30 to 40% of them didn't actually fuse. When you attempted to do a fusion, you attempted to get the bones to grow together. Well, you failed because you're trying to fuse the facet joints basically, and they're so little that there's not enough surface area and compression and loading to get the bone to grow. So pretty much all the fusions we do today, we take the disc out because that's where all the action's happening. Take the disc out, put some bone in the disc space, get it to fuse. The only real question for us is how are we going to get to the disc space? Are we going to go from the front, the side, or the back? Going in from the front is called the ALIF because the A means anterior, which means from the front. Going in from the side is a lateral, an LLIF, so we're going in, the lateral means the side. Going in the back is either called a TLIF or a PLIF. TLIF means transforaminal, which means you're going through a facet joint, and PLIF means posterior. And those two are my least favorite because the hole you work in is not very big because the nerves are in the way. You got to go in between the nerves to get to the disc if you go from the back. Whereas if you go from the side, the nerves are much less in the way. And if you go in from the front, there's really no nerves in the way at all, but you got blood vessels. So there's a positive and a negative to all three different approaches. And quite frankly, you really want a surgeon who does all three approaches so they can pick which one is best for you based on your pathology. And some surgeons kind of get locked into doing the same one, and they just do the same type of approach on everybody because they're good at it, which is okay. But in an ideal world in this day and age with so much training and practice and YouTube videos where you can watch surgeries, surgeons should really be able to do all three. And then, like I said, the patient's pathology should dictate which one you do because they're all good. They all have their pluses and minuses. Going in from the front, the ALIF gives us the best exposure to the disc. and allows us to jack the disc back open and restore the deformity. You know, as we get older, the disc collapse down. You get more and more kyphotic or bent forward. And that's what happens when the discs degenerate. They collapse down in the front. That's why old people get more and more bent over. So if we're going to fuse somebody, we don't want to fuse you stuck in that bent forward position. That's going to put more stress on the other levels. The chance of another level falling apart after having a fusion is around 20 to 30%. Well, it's going to happen more likely if we fuse you bent forward because your whole torso is jutted forward. It's going to weigh more, put more stress on those other discs. So if we're going to fuse you and stop the motion, at least we want to correct the alignment. We want to jack those discs back open, put you to more normal height, bring your torso back over your hips so that it'll put less stress on the other discs and hopefully preserve those other discs and help prevent them from falling apart. So the anterior approach from the front gives the best exposure to jack open the discs. The downside is if people are obese, it can be hard to go in the front. A lot of fat to get out of the way and it can be more dangerous. Also, you have blood vessels sitting on the front of your spine, and we have to move those out of the way to get to the spine, and that can be dangerous. And there's some other complications. You can get a thing called retrograde ejaculation down at L5S1, and going up higher, there's a lot of blood vessels in the way. And the recovery can be longer if you're going from the front because you can get a hernia, and it can disturb your rectus muscles in the front. So going in the side has been around for about 10 to 15 years, even longer, but it's gotten more popular in the past 10 to 15 years. Some of the reasons why going in the side have gotten more popular is because the technology has improved. We now have neuromonitoring. So in the surgery, we actually put sensors in the muscles in the legs and do some neuromonitoring so we can see where the nerves are, or at least we get some feedback as to where the nerves are. We also use X-ray. We use a fluoroscopy with much more adeptness because using the X-ray machine, we can make a very small, minimally invasive incision and put a tube down and lock it in place and know based on our X-rays that it's locked in the proper position and the surgery can be very safe. So there's been some technological advances that have made our ability to go in from the side much safer and easier. And that's one of the main reasons why it's increased in popularity and usage over the past 10 to 15 years. So we still go from the front, but going from the side can be safer and less invasive, especially at higher levels in the lumbar spine. So we put a patient on the side and basically the whole abdomen falls forward. So if it's an obese patient, it doesn't really matter because all the fat falls forward and gets out of our way. And then the blood vessels that are on the front of your spine, well, we don't even see those. And they're there. There is a risk. You got to know what you're doing. You got to stay focused. Goes right down on the spine. But we don't have to move the blood vessels out of the way. So they're usually not even an issue. Whereas going in from the front, they are. And so there's some distinct benefits from the side. And the incision's much smaller. The incision is about 2 inches. And we're able to put in these spacers that are about 2 to 3 inches long. They're about 2 inches long. And through a 2-inch incision. So the spacer's as big as the incision we make, which really allows us to get great correction of the deformity of the spine through a very minimally invasive approach. Then the other option of a technique going in from the back, doing the DLIF or the PLIF, well, as I mentioned, that's my least favorite option because I have to work through nerves in order to get to the disc. So there's a higher risk of an injury to those nerves because I got to move them out of the way to do the surgery. And the other component is the hole I'm working in, my access is so small that the spacer we put in from the back is only about a third of the size of the spacers we can put in from the side or from the front. And because the spacers aren't as big, we typically don't get as good correction of that deformity we were talking about. So I still do them from the back, and somebody who's old or obese or sick or for whatever reason, it's still a good surgery. The results have been shown to work, but it's not as good for correction of the deformity. And I think it can have a higher risk because we got to move the nerves out of the way. And that's been shown through a lot of studies. We actually did a research study that was published several years ago that compared going in from the front, the side, and the back. So comparing the ALIF versus the lateral versus the TLIF from the back. And we basically showed that from the front got the best correction. Going in from the side got half as good. Going in from the back got no correction. And that's basically what we thought. And it has to do with just the biomechanics and the access that you get to the spine. So how do we do the surgery? As I mentioned, we position a patient on their side, and that allows their abdomen to fall forward. One of the keys in the positioning is taping the person in a neutral position where they're not going to move. We really want to lock that patient in so they're not going to move. And we use the x-ray to make sure that they're not rotated or that they're not tilted. If the disc we're going to work on is straight up and down to the floor, and we make an incision right over the disc on the skin, if we just go straight down, the surgery's pretty easy. And I love teaching this surgery. I've taught it all over the world to hundreds of surgeons and really helped them with their practice because, and I was taught the surgery, obviously, and passing this on to other surgeons where you know you're going to help them take care of people with a low risk, high functionality surgery is really gratifying. And it's a fun surgery to teach. And one of the big keys is the setup. If you set the person up and you go straight up and down to your incision and use the x-ray, it's pretty hard to mess up. Although complications can always happen and sometimes are almost unavoidable. But anyway, you make the incision right over the disc, you go straight down. If you drift anteriorly, if you drift into the front, you can get into the organs, the intestines, the bowels, the blood vessels. You can have some real complications. If you drift posteriorly into the back, well, you can get into the spinal canal where the nerves are and get weakness and numbness and those types of things. So you want to really set the person up where the patient is straight up and down, make the incision, go straight down, don't drift, just go straight down. And basically we look down the hole, we bluntly move the muscles out of the way. The abdomen falls forward. There's retroperitoneal fat. I actually wear magnifying loops and wear a headlight so I can look down. And then we basically dissect the fat off of the muscle, and we see a red muscle belly right in the bottom of the incision. That's the psoas muscle. And the psoas muscle sits on the side of your lumbar spine. It goes down, and it's a hip flexor. So one of the downsides of this surgery is people can get hip flexor spasm and weakness after the surgery because we've gone through that muscle, and it can cause some pain and muscle spasms. It's usually temporary. It usually goes away, but that is one of the downsides of the surgery. And so we see that red muscle. Now, more and more, I go very anterior to that muscle. Sometimes I barely even go through the muscle because I go in the front of it, and I pull it back and then see the disc space and then take a neuromonitoring probe and put it down on the disc. And I turn it on. And the neuromonitoring probe sends an electric signal through the probe. And basically, if I'm near a nerve, and these nerves are going down into the leg and innervating the muscles in your legs, if I stimulate the nerve with this electric signal, the muscle will twitch, the muscle will fire. And then my neuromonitoring tech will tell me I'm getting a response in the muscle, which means I know I'm close to the nerve or touching the nerve, and I want to avoid it. So one of the risks of the surgery is you can get weakness in your quadricep or a muscle in your leg or an adductor if these muscles get traumatized during the surgery. And so this neuromonitoring helps us know where the nerves are. Plus, I'm looking down the hole. So I can see a nerve, I can touch it, get a positive response and know it's a nerve and know I don't want to hurt it. And then typically I'll move in front of it. I'll go more in front of the nerve. Now you can retract nerves. I can go in front of the nerve and retract the nerve a bit, but you don't want to traumatize it. You just want to gently retract it, and you can go in front of it if you need to. But anytime you move a nerve, there's always a risk that somebody can get weakness from even touching the nerve. Sometimes we can just look at a nerve and somebody may wake up with some weakness, but obviously that's usually temporary and usually the nerves recover. But obviously with every surgery, there's always a risk of some permanent issue. Sometimes things happen we can't even predict. But the safest way to do the surgery is look down there, go in front, go through the muscle, dock right on top of the disc space, check your neuromonitoring, and if you know you got a safe window, then it's a pretty safe surgery. Because then what I'm going to do is, over that neuromonitor, I'm going to dilate over it. I'm going to take these conical shaped tubes, 3 to 4 of them, that go over the neuromonitoring, progressively getting bigger until I'm going to work through a space which is about an inch wide. It's about 2 centimeters wide. In fact, it's less than that. It's about 2 centimeters, which is just less than an inch. And through that tube, I'm going to do all my work. And in fact, the retractor I use, there's a million different retractors. They're all effective in their own way. The retractor I use has 4 different blades that all move individually. So I call it a gentleman's retractor because I can move individual muscle fibers out of the way and really get a very clean, gentle exposure where all I see is the disc. And if I know that all I see is the disc and there's no blood vessels and there's no nerves and there's no intestines or organs, the surgery's basically done because my tube gets locked into place straight up and down. Then all I got to do is take the disc out, clean all the disc material out of the disc space, put my spacer in, and the case is done. So usually it takes about 10 to 15 minutes to do this exposure, get our tube in place, and lock it in place. Now the fun part comes. Now I'm going to take the disc out. I basically cut the disc, clean all the disc out, get all the cartilage out, all the soft tissue. Remember, we're doing an interbody fusion. We're going to fuse the two bones together. Well, I got to get rid of all the soft tissue and the cartilage because that's blocking the bone growth. That's going to block the fusion. So we get all the disc material out, get all the cartilage out, release the soft tissues. And then once all that's cleaned out, then I'm going to put a trial in. And we have different size trials, 0 degree, 6 degree, 12 degree, 18 degree, different heights, different lengths, different widths. There's so many different options. It's crazy, but it's great, obviously, because it can really fit the patient's anatomy. And I've worked in other countries. Some other countries, they only have 2 or 3 sizes, and they just got to make it work for each patient. One of the nice things about working in America, we have a lot of different options. There's probably 60 different trials and sizes that I can use based on what is the best pathology, what fits that patient the best. So basically, we put our trials in, we do it under x-ray, we get a good fit, we want to make sure that we get good correction, but don't push it too hard. If we use too big of a trial or too big of a spacer, or if the person's bone is soft, you can always get subsidence of the spacer. We try and avoid that happening. Sometimes you can't avoid it. Sometimes it just happens. But you try and get the proper spacer that's going to get good correction, but don't push it too hard. And then basically we get our right size, and then we put our spacer in. And the spacers can be made of metal or plastic or bone. They can have biologics with it to help stimulate the bone the bone growth. We can use the patient's own bone. There's all different sorts of mix and matches that different surgeons use that all can be very effective. We put the spacer in, and that stays in forever. And most of the spacers have big holes in the middle, and that's where the bone is going to grow through the middle of the spacer. The spacer is there to just hold the bone in place and to hold the correction and get the bone to grow. The bone's going to grow through the spacer and around the spacer to connect the two vertebral bodies, and that's the fusion. So as far as putting the trial and the spacer in, that usually takes another 10 to 15 minutes. The whole surgery generally takes about 30 to 40 minutes. We can do multiple levels. We can go do other levels as well. And then typically I will back these spacers up with screws, pedicle screws in the back. Now, sometimes I can put in one-sided screws in that same lateral position. The patient's on their side, and I can put in 2 screws from that side position. Other times I'll turn the patient face down while they're still asleep, put in 4 screws in the back, 2 on both sides. Sometimes we use clamps. Sometimes we use smaller screws. Again, there's so many different options, different things to use, but typically I'll back it up with screws because, see, the spacer gets the correction and it has the bone graft in it, but it doesn't provide a lot of stability. It doesn't stop the motion. And you know, when you break your arm, you've got to stop the motion in order for the fracture to heal. You put a cast on it. The cast stops the motion so the bone can grow. Well, the same thing in your back. If we're going to try and fuse it, we got to stop the motion. We got to put a cast in there. Putting in screws with rods to lock it in place will stop the motion, which will allow the bone to grow. And that's why we use those. And typically all this stays in forever. There's typically no reason to remove it. Another risk of the surgery is for infection. If you ever had an infection, sometimes we have to go in and take it out. That's extremely rare. Screws in the back, very rarely. The muscles may get irritated. We may go in and remove them. But typically everything we put in there stays in forever. And most people, after 3 to 6 months after the surgery, don't even really know they're in there. Now, it's worth noting that a fusion means we're going to stop the motion at that segment. So by definition, that segment's never going to move again. So the patient is going to lose some motion, flexion, extension, rotation of their back. But most people with a one-level fusion don't really notice a functional change in their motion because a lot of them had pain and pathology before the surgery, so they weren't moving normal before the surgery. So the surgery may decrease their pain, so they can move more, but that one segment's not going to move, so it usually balances each other out. Our typical results of doing this type of side fusion with some screws in the back, people's preoperative pain averages an 8 out of 10, and postoperative pain averages a 3 out of 10. And I love knowing those numbers because it gives people a realistic expectation where if you're at an 8 out of 10, where you're in pain all the time and it's killing you, you can only stand and walk for 5 or 10 minutes and you can't even enjoy your life, and the surgery takes you from an 8 to a 3, well, Well, that's a good reduction, and people are happy, and that's worth the risks of doing the surgery for getting that type of reduction. So that's good. The bad part is people after this surgery average a 3 out of 10 pain. Now, some are at a 1, but then some are at a 5. So why do they average a 3 out of 10? Well, because typically most people have pathology at other levels too. And the difficulty thing about spines is we can't fix everything. We're not fusing your whole body. We're only going to fuse 1 level, 2 level, whatever we think is the most painful, but you may still have pain from the other levels. There's other moving parts. That's why the spine is so much more complex and interesting than other joints. Hips or knees, you just replace the hip or the knee and that's the end of it. Spines aren't like that. For spines, you've got a disc in the front, 2 facet joints in the back, 2 nerves coming out at every level, and there's 5 different levels all in just your lower back alone. And it keeps going. Your thoracic spine has 12. Your cervical spine has 7 more. It never ends. And so that's what makes it more complex and interesting. But that's why a lot of people can still have pain after a fusion, because you can have pain from the other levels. The other component is you may have some pain from the stiffness of that segment and the neuromuscular dysfunction. Also, people typically who have back surgery have been in pain for 5 or 10 years going in. So there's memory to the pain, and this disuse of your body has built up pain patterns and dysfunction that the surgery may help you, but it may not cure you and it may not make you perfect. So typically after the surgery, most people stay in the hospital for 2 nights. That's the average. Some only 1, some 3, but 2 is about the average. People get up and walk right away. Same day of the surgery, we get people up and walking because the spacer in from the side and the screws in the back are so strong that you can get up and move right away. I tell most people they'll have pain when they twist in bed and when they try and get in and out of bed when they change position. And sometimes people get paranoid and they think, oh no, I'm messing up the surgery because it hurts. And if it hurts, I shouldn't do it. But in reality, this spacer and the screws are so strong that getting in and out of bed and twisting and rolling over in bed, you're not going to mess up the surgery. It hurts when you do that, and that's typical for the first couple weeks. But then once you get up and move, most people feel better. And most people, the first time they stand up, they tell me, I don't feel the nerve pain. I don't have that crazy pain I had before the surgery that I came in with. That pain is gone. Thank God it finally went away after years. But I got pain from the surgery, the muscle pain from the surgery. And the muscle pain from the surgery typically lasts about 6 weeks on average. Some people have no pain after 2 weeks. Some people have pain forever. But 6 weeks is about the average. I tell most people plan on taking 2 weeks off of your life. Don't plan on doing anything for 2 weeks. No appointments, no driving, no meetings. If you work, you can work from home after generally 5 to 6, I'd probably say a week. After a week, you could start doing computer work from home and calling people, but you really want to take 2 weeks off. And if it's a physically demanding job, you may be out of work for 6 to 12 months. And so there's a wide range in there. And so part of that is it takes 3 to 6 months for the bone to grow. So the fusion takes 3 to 6 months and can take up to a year. Generally, by 6 months, we know whether somebody's going to fuse or not, but it can take up for a year, even 2 years for the bone to remodel and fully mature. So you got to give your body time for this bone to heal. We start the physical therapy typically 8 to 10 weeks after the surgery because we want some bone growth in there where that bone is really growing. And then our whole physical therapy program starts with the spine in neutral. So you learn to find that neutral position, and the dead bug exercise is a great place to start. It's in our app, the Back Doctor app. But you start at level 1 of the dead bug, learn how to find that pain-free neutral position and lock your body and lock the muscles in to maintain that neutral position. Then you just move your arms and legs and start to breathe and work on balance and coordination where you're locking your spine in neutral. So you're not going to stress your spine. You're not going to stress the surgery. You're not going to stress the other levels. So you start at level 1 of our program. 5 is the hardest. When you get to level 2 is typically when we let people do an elliptical, swim, and bike. When you get to level 3 is when most people have really completed the program and go back to most things in their lives. And that typical return is, it takes about 3 to 6 months for the bone to grow, and then it takes 3 to 6 months to rehab your muscles after the surgery. So return to most of your activities and everything you want to do is going to be 6 to 12 months. So this concludes our talk on the DLIF, XLIF, lateral interbody fusion. It's been a great instrument that's really helped our patients significantly. There's obviously risk with any surgery. Talk to your doctor, your surgeon about what's the best approach for you. If we can help in any way, feel free to call or email. And best of luck to you in the future.